Good afternoon, all. Welcome to National Initiative to Strengthen Collaboration between HIV/TB through e-learning session. I am Dr. Vandana Dabla from Share India, and we are here again to discuss about HIV/TB. And today, I welcome all the participants and ART centers we have with us from Delhi, Uttar Pradesh, Tamil Nadu, and Andhra Pradesh. So, and here in the studio, we have our clinical expert, Dr. Ananya Prabhu. Thanks for coming and joining Dr. Ananya. Dr. Ananya is a specialist at National Institute of TB and Respiratory Diseases, New Delhi. So today we are going to discuss very interesting thing. We have recently seen the various updates happened in the TB guidelines, TB treatment guidelines. They have been into various parts, that is the adult one and the pediatric one. And today's session is to discuss the updates in the guidelines on drug-sensitive tuberculosis in adult PLHIV. So I think it's gonna be very interesting one. But before we start, I think it's time for the attendance. I request you all to please fill up your attendance. You will be seeing here right now on your screen. So while everybody is registering their attendance, I request you to please follow the naming convention. Please write the name of the ART center, or if you are from some other institute, write the name of the institute, because otherwise we are unable to recognize. For example, we have on our screen one participant named HP. So HP is the name of computer. We don't know from which place you are, or the name of the phone is coming on the screen, like Oppo 57. We have been requesting all of you to please follow the naming convention. Thank you all. Thank you for registering the attendance. So now it's time for the pre-test. You will be seeing two questions related to the topic which we are going to discuss, that is the national guidelines update. So on your screen right now, you will be seeing the pre-test. So there are two questions. Please read the questions thoroughly and please select the answer which you feel is right. Okay, so first question says that at your ART center, you need to start drug-sensitive TB treatment to a PLHIV. Now, this PLHIV is having a history of TB treatment for only 2 months. That means previously the patient had taken TB drug for 2 months. So now, which regimen would you recommend? You're starting again the TB regimen. CAT 1, CAT 2, or you think patient should not be started on TB at all, TB treatment at all, or you will start CAT 4. It's a very interesting one. We will be discussing these things in the session also. And question 2 is very simple. You need to read the statements and tell like which statement is false. That is not correct. Thank you all for the pre-test. So now it's time for the presentation and the didactic. So I request Dr. Nanya, Madam, I think it's time we can start with the presentation.
Good afternoon, everyone. So today's presentation is on recent updates in national HIV TB treatment guidelines for drug-sensitive TB in adult PLHIV population. What are the session objectives? I hope by the end of the session, we know the rationale for moving to new anti-TB treatment protocol, standards for TB care in India, various definitions of types of TB, treatment outcome, categories of treatment regimen and their drug doses, and very important, the breakthrough implementation that came in December 2018, discontinuation of category 2 treatment for the previously treated patient. Coming to the first point, what's the rationale for moving to the new anti-TB treatment protocol that we have? As we all know that India has a very high relapse rate, which contribute to continued transmission of TB, and it is one of the reasons for high TB burden in the country. Out of the total relapse cases notified in high burden countries, India contributes to about 50%, which is quite a magnificent contribution. Higher pre-treatment INH resistance, that is range of 11 to 16% in new smear positive TB patients, continue to contribute to high treatment failure rates and increased emergence of rifampicin resistant mutants. So what's the need of the hour? Need of the hour is effective daily drug regimen, which enhances the patient acceptance and treatment adherence. So on what factors does the efficacy of anti-TB regimen depends on? One very important point is successful early outcome, which is indicated by high sputum conversion, Sputum conversion is the time a sputum positive, smear positive specimen takes to become smear negative. It can be like in a good anti-TB patient, if is taking a good anti-TB regimen and the program is running well, generally a 2-3 months of the sputum conversion time is taken as a good operational indicator, which converts in 2-3 months. And another point is high treatment success, that is to be smear negative at the end of the treatment. Coming to long-term outcomes, obviously low relapse and low emergence of drug resistance. So the newly formulated daily anti-TB treatment with 3-drug continuation phase will be effective, having all the desired qualities stated above. Coming to standards for TB care in India, it was felt that India should have its own standard. It should lead in teaching TB guidelines that could be used as a benchmark by all providers managing TB patients, even across the world and within India. A set of standards recognized as appropriate for specific challenges of India, which spur observance to these standards by all care providers of India when managing TB patients. These are the standards for TB care in India. So there were 26 standards developed after a national workshop. Standard 7 was pertaining to the treatment with the first line treatment, and they were like treatment of new TB patient. Initial phase, we give all the four core drugs: isoniazid, rifampicin, pyrazinamide, and ethambutol for 2 months. And the continuation phase, you give 3 drugs: isoniazid, rifampicin, and ethambutol for at least 4 months. So this was changed. Ethambutol was added because, as I said earlier, there's a high pattern of drug resistance that was observed with high INH resistance. So ethambutol was given as a companion drug to prevent the rifampicin resistance from happening. As a companion drug to prevent drug resistance, at least one effective drug. If there's a high H mono resistance, then there will be a high degree of rifampicin resistance also happening, because you'll just be giving one drug to a failing regime. So we are adding ethambutol as a companion drug to prevent the drug resistance from happening, and we give that in the continuation phase for all the 4 months. And then there's extension of continuation phase. We extend the continuation phase by 3 to 6 months in special situations like bone and joint TB, spinal TB with neurological involvement, and neurotuberculosis. Drug dosage of these 4 drugs is as per body weights and different weight bands, which we'll discuss later. Then what is important is bioavailability of drug that is ensured for every batch. Daily is the key word. Now we switch to the daily ATT and FDC. So these two are very important points that happened in last 7-8 months, that we switched to a daily ATT, and we are switched to the good FDC that we are getting now. This is type of TB. There's not much new, nothing new in it, but still just a revision. TB patient, new TB patient has never been treated for TB or has taken anti-TB drug for less than 1 month, and it's considered a new case. Previously treated is a patient who has received 1 month or more of anti-TB in the past and is considered as previously treated, and there's various subsets of that. A recurrent previously treated patient is the one who has been declared as successfully treated, either cured or treatment completed, and is subsequently found to be microbiologically confirmed TB case. That is either by sputum or CBNAT. They are microbiologically confirmed TB case. Treatment after failure is a TB patient who has been treated for TB and his treatment failed at the end of their most recent course of treatment. Treatment after loss to follow-up. Earlier we used to say default, so this has changed. A TB patient previously treated for TB for 1 month or more and was declared not to follow up in the end of their most recent course of treatment and was subsequently found microbiologically positive. Rest all are other previously treated patients. A transferred in patient is a patient who is received for treatment in a TB unit after registering for TB treatment in another TB unit. Cure, microbiologically confirmed TB patient at the beginning of treatment who was smear or culture negative at the end of treatment completion. End is important, not just any smear at any time of the treatment, at the end of treatment completion. And treatment completed is a TB patient who completed treatment without evidence of failure or clinical deterioration, but with no record to show that smear or culture of the results of biological specimen in the last month of treatment was negative, either because the test was not done or because the result is unavailable. Treatment success, TB patient either cured or treatment completed, account for treatment success. Failure, very important. A TB whose biological specimen is positive by smear or culture at the end of the treatment, that is just what we don't expect, opposite of cured definition. And it is another thing, failure to respond. A case of, that's in a pediatric TB who fails to have bacteriological conversion to negative status or fails to respond clinically or deteriorates after 12 weeks of completion of IP shall be deemed to have failed respond provided alternative diagnosis and reasons for non-response have been ruled out. Lost to follow-up, a patient whose treatment was interrupted for 1 month or more. Not evaluated important, no outcome assigned, treatment regimen changed, switched to drug-resistant TB, died during the course of anti-TB treatment. Now, this was an old recommendation we had. Like we had new TB patients and we had previously treated patients, and they were given 2 different regimens. And we had our good old streptomycin in the previously being given in the previously treated cases. So what changed? This changed everything. This communication came to us in December 2018 from the Government of India, and as per the recommendation of technical expert group on treatment of TB, it was decided that the current regimen for previously treated TB, that is erstwhile known as CAT2, will no longer be used, and all the previously treated patients will be initiated on standard first-line anti-TB regimen, that is 2 HRZE and 4 HRE as prescribed for the new TB patient. So this was a very important and a recommendation, a breakthrough recommendation that came in. And what was important, a few more important points that we should remember is that DST should be conducted for at least isoniazid and rifampicin for all notified previously treated TB patients, and the most appropriate regimen should be prescribed as per the program guidelines. And all efforts are to be made to get the DST before the start of treatment in case of previously treated cases. But the results should not be awaited for starting the standard first-line anti-TB treatment, and because it can be changed later on the basis of DST profile. A standard 6-month first-line regimen may be continued if no resistance is detected to H or R. So this is a very important recommendation. And what another problem that we face in daily life when we don't have the DST results, when there are no appropriate specimen for this, is a very common case scenario in PLHIV patients who are not producing enough sputum or who are very sick and they don't give sputum at all, and so we cannot guide our treatment on the basis of DST. In that case, the recommendation is that we do not have appropriate specimen for DST. They should also be offered a standardized first-line regimen for TB and followed clinically, radiologically, and microbiologically to identify any signs of non-response to treatment during the course of treatment. And in case of non-response, attempt should be made to obtain an appropriate specimen during the follow-up visits and further management as per the RNTCP and PMDT guidelines. Another thing I would like to clear is that there's a lot of confusion because we must remember that the categorization still remains. We still call them previously treated and they are still subcategorized into relapse, failure, treatment, and loss to follow-up and other previously treated. But the treatment being given to new and previously treated is same. The category 2 regimen has been abolished, but that nominal categorization that we call them previously treated to differentiate them from new patients, that still exists. So that is very important to remember. Follow-up schedule is almost for previously treated and new is almost the same because they follow the same treatment. And so this was the most important breakthrough implementation that came, and I hope we all follow it very diligently. And so based on this regimen recommendation, this is a new anti-TB treatment that we have. That is, whether the patient is new or previously treated, we give them the same regimen. That is 2 HRZE plus 4 HRE. So I hope there's absolutely no confusion on this, because many people have this confusion that okay, we'll give it for 8 months, we'll give the same drugs for 10 months. No, it's the same regimen, same duration. Now doses, because this is depends on the doses. We switch to FDCs, and we have 8 weeks of treatment in intensive phase into 7 days. So we get 56 doses in the initial phase, and we have 4 months, 16 weeks, and into 7 daily treatments, so 112 doses, 112 doses. And at the end of 2 months, we do a DSP. There's no extension of intensive phase. Continuation phase, as I said before, would be done in both new and previously treated cases. It may be extended by 12 to 24 weeks in certain forms of TB, like I just said, CNS, skeletal. Extension beyond 12 weeks could only be on recommendation of experts of the concerned field. So we are talking about the CP phase. What is important to remember is that IP phase, we just do a DSP, and if it's rifampicin sensitive, we go on to the CP phase. There's no, like earlier we had that after we'll extend the IP phase. Now that practice has been recommended, it should be stopped. This is how we get our fixed dose combination ATT. This is how it looks. This is for the intensive phase 4 FDC, which has rifampicin in the dose of 150 mg, isoniazid 75 mg, pyrazinamide 400, thambutol 275 mg, all in one tablet. And this is a 3 FDC combination, which does not have pyrazinamide, and rest are safe. So what is the advantage of fixed dose combination? We must know, because now we are following it. First is obviously simplicity of treatment. It increases patient acceptance, fewer tablets to swallow. It prevents concealed irregularity and selective drug avoidance, because if a patient knows that, okay, if I eat ethambutol, I get more gastritis, then he will just not take that medicine, hide the medicine under his pillow, or just avoid taking that medicine and take other three, which leads to inadequate treatment and more failures. So this concealed irregularity, when the patient is not reporting that I'm not taking all the medicines, is avoided by the fixed dose combination. Then there's increased health worker compliance. There are fewer tablets to handle. This is and quicker supervision of DOT, easier drug management for obvious reasons, reduced use of monotherapy. Just like I just said, that patient cannot choose which all drugs he want to have. He has to have all the 4 drugs. So there's lower risk of misuse of single drugs, lower risk of emergence of drug resistance, and this FDC is easiest to adjust dosage by body weight bands. The only disadvantage, the only problem comes is when we get some reaction, when we get drug-induced hepatitis or some adverse reaction, and we do the reintroduction. We cannot do it with FDC. Then we go to the individual drugs to see which drug was the culprit drug. So that's the only major disadvantage of FDC. Otherwise, there are more advantages, and risk benefit ratio is always, benefit is always higher with FDC. Now, this was an old recommendation. These were the older weight band when we started, and this has been changed now. So this has been changed from in May 2019 itself. So the recommendation which came, this was that TB patients up to 18 years of age should be given treatment as per chart of child doses as children, and weight categories for FDCs were changed, and this was changed to 25 to 34 weight 2 FDCs, 35 to 49 3, 50 to 64 4 FDCs, 65 to 75 5, and more than 75 kgs, it was 6 tablets. So, and another thing, another important recommendation was, and in previous old recommendation, as you can see, the dosing will remain changed even if the weight band changes during the entire course of TB treatment. But after this recommendation says that an adult new or previously treated, after being initiated on treatment, whose weight increases or decreases by 5 kgs or more compared to baseline weight, and also crosses the current weight band during the course of treatment, the weight band must be changed at the time of issuing the next script to the patient. For pediatric, which will be dealt later in details, change in weight band should be carried out more immediately. And so this is something we need to remember, the weight bands. And according to it, the various fixed doses that we give, number of pills, number of strips. So remembering the weight band is most important. That it has been changed from 20, it has become 20 1 to 5 weight bands are there. So this is the most important recommendation. And number of strips, number of doses remain the same. Doses remain the same because the duration has not been changed. Only the weight band has been. Now coming to some basic adverse drug reaction and drug-drug interaction that we see when we give TB HIV treatment. Okay, coming to isoniazid, we are all very familiar with this drug. Peripheral neuropathy, as we all know, tingling, sensation, numbness that the patient comes with, is the most common toxic manifestation. And TB patients with HIV are more prone for this peripheral neuropathy. And it can be prevented by giving pyridoxine. And they usually complain of lightheadedness, lethargy, and with and fatigue with intermittent doses. But in daily doses, this it can be prevented. And daily doses, less of the side effect. Isoniazid-induced hepatotoxicity is there. We all know. We discuss in detail. It is reversible. And one more thing that we see very frequently with isoniazid is that we see patients getting little psychosis and little they talking incoherently. So that can also be due to INH, and then we have to stop INH for some time to see whether the INH was a culprit drug. And INH INH interacts with anti-epileptic drug. It can itself give rise to epilepsy. And it increases the serum concentration of phenytoin and carbamazepine, which are anti-epileptic. Its absorption is impaired by antacids. So, few important drug interactions we must remember, especially if we are seeing some neurological side effects in patients. Coming to rifampicin, it's well tolerated by most patients, especially on daily doses. And rarely serious hepatotoxicity occurs. Generally, it's cholestatic pattern, that's biphasic, that there will be a rise of bilirubin, but after some time that bilirubin level goes down as the liver adjusts to the new metabolism. And the very harmless effect, it causes orange red discoloration of body secretion and may result in permanent discoloration of soft contact lenses as they are secreted in our body secretions. These are the serious side effects that we used to see when we were giving intermittent regimen, like cutaneous syndrome, which is flushing with or without rash, abdominal syndrome, and flu syndrome. So, what was important was that whenever we used to get this serious side effects, especially purpura or acute renal failure, rifampicin was never ever has to be reintroduced if we get a renal failure or a purpura. So that was the main because we used to get it when we were giving intermittent regimen, but with daily regimen we are not seeing this very frequently. It hardly happens. Then coming to pyrazinamide, joint pain is the most notorious side effect of it, and we usually manage the arthralgia without discontinuing the drug, and we give analgesics. There can be asymptomatic increase in serum uric acid, and it does not require treatment. Severe hepatotoxicity we usually see when we give both H and R together, and sometimes it's difficult to reintroduce pyrazinamide because the hepatotoxicity comes back again when we are dealing with DIH, but we still see and hypersensitive reaction can occur occasionally. Ethambutol, we all know it causes retrobulbar neuritis, so there's impaired vision. So ocular toxicity seems to be dose dependent, so we have to keep a watch on that. That's why it's still difficult to give in pediatric patient, and we keep a watch, but in adults because they can tell their symptoms. And vision usually returns to normal within a few weeks if the drug is stopped, but the optic nerve may be permanently damaged if ethambutol is continued. Coming to streptomycin, though now the category 2 is not there, so use of streptomycin is not there, but still has some hypersensitive reaction, and we all know that it's contraindicated pregnant women, and some minor adverse effect like tingling and circummotion, but this is not much important because now we are not going to give streptomycin to our previously treated patients. Coming to some common and rare side effects, common, I just said that nausea, vomiting, gastritis, hepatitis, cutaneous reaction, and rare are those like flu-like syndrome and myelosuppression, anemia. So one very important side effect we see is drug-induced hepatitis. So what do we do? we generally see that we have to see whether the patient is symptomatic or asymptomatic, because liver enzymes will rise when you give ATP. But it is very important to see whether the patient is symptomatic or asymptomatic. If it's asymptomatic, we really should not worry much about until the levels are 5 times or more. But if it's the patient is symptomatic, then we need to worry, and all drugs must be stopped until the jaundice or hepatic symptoms have resolved and liver enzyme have returned to baseline level. And it is other causes of hepatitis must be stopped, like hepatitis, like alcohol, or it is very common in above 35 years, alcohol, or if there's hepatitis E, hepatitis infections. Then it is advisable to wait for 2 weeks after the jaundice has disappeared before starting the tuberculosis treatment. So the reintroduction of drug that I was telling, this is the disadvantage with FDC, that we cannot do reintroduction with FDC. We have to go back to our individual drugs. It's generally, it is preferably done in hospitalized patient. You don't expect the patient to understand the introduction process very well. And we tend to give maybe 50, 100 and 100 mg of isoniazid, and we observe for 3 days, then repeat the LFT, then give another, then give rifampicin again at 75 mg day 1, then 300 mg day 2, and then give the full dose. And all these 3 days when we are introducing the new drug, we have to keep asking the patient if he's having any symptoms of hepatitis like jaundice, nausea, vomiting, or his symptoms are coming back, so that we know which drug was the one which was responsible for his hepatitis. So we have to keep a very watchful eye and keep repeating the LFT after every 3 days of starting a new drug. Other reactions, hepatotoxicity I just said. Then ocular is main is ethambutol, and it is not recommended to give ethambutol again. Coming to nephritis, the main suspecting is drug is rifampicin, as I said, and we usually used to see it in intermittent regime, and reintroduction with rifampicin is not recommended. Cutaneous reactions keep mild skin itching, which generally managed with anti-allergics. But if we see a serious reaction, that is when the mucous membrane gets involved, then we need to worry, and if reintroduction drug is not recommended. Otherwise, skin reaction, we have to see the severity and then decide. Then immune thrombocytopenia, rifampicin, main suspect is rifampicin, and reintroduction is not recommended. Aplastic anemia, we have to ask for a blood picture. It's usually the INH. Nephrotoxicity, because we are giving a lot of aminoglycosides to the patient till last year. The main suspect drug are aminoglycoside, and reintroduction at low dose can be given after the renal function returns to normal. Ototoxicity again is aminoglycoside, and recommendation is not recommended because it's permanently ototoxic damage. In renal impairment, it's important to know that our 2 very good drugs, 4 drugs, thankfully they are safe, isoniazid and rifampicin. And pyrazinamide and ethambutol, we just need to do dose adjustment, that we need to make them 3 times a week instead of daily, and we are able to manage patients on this. Renal impairment, if the creatinine clearance is less than 30 ml per minute per patient, or for patient receiving hemodialysis who are like frank renal failure cases, then we need to modify dose and frequency. Like I said, for pyrazinamide, it becomes 25 to 35 milligram per kg 3 times a week, but not daily. Ethambutol also 15 to 25, 3 times a week, not daily. And streptomycin, now we don't do 12 to 15 milligram per kg, 2 or 3 times per week. Now, coming to the role of antiretroviral therapy, PLHIV with TB. So, what is the role of it? We of ART, PLHIV patient has a TB. We all know we have to treat the TB. We have to treat the opportunistic infection first. But alongside now, we start the ART. We have to know that we have a back of our mind that we have to start ART as soon as possible. That is because we want to prevent reactivation of latent TB in HIV infected, and we want to reduce short-term TB-related morbidity, we reduce recurrent cases, and the most important is that we want to reduce long-term mortality after an episode of TB. So this was a recommendation in patient with initiating first-line ART in PLHI with TB co-infection, that you start ART regardless of any clinical stage and any CD4 count. I think this is one point where we are still lagging, because there doesn't seem to be clarity unanimously. People are still confused that whether we should start ART immediately or should we take care that so much of side effects are there, so many drug interactions are there, and they don't follow the real recommendation. But this is the recommendation: you start ART regardless of any clinical stage and any CD4 count. And for patient with CD4 count below 50 cells per cubic meter, you try to start within 2 weeks. So you first start the AGT, and then you try to start the ART within 2 weeks. For others, you can wait till you want to start as soon as possible, but between 2 months that we are usually able to put them on both the regimens. But for a lower CD4 count, because of the risk of mortality, we want to start it within 2 weeks. Now, when we think of TB HIV, the most notorious drug interactions are rifampicin with the ART, and that is rifampicin is an inducer of, because rifampicin is an inducer of many enzymes of cytochrome family, which are involved in drug metabolism also. So it speeds up the metabolism of any drug metabolized by these enzymes, that is the P450 superfamily, due to which, or due to induction of P450 enzyme, there is suboptimal concentration of antiretroviral drugs, and because of as a effect, there is a decreased therapeutic effect, and because we have subtherapeutic levels in our body, because we have a chance of developing resistance to those antiretroviral drugs. So this is very important, that rifampicin induces P450 enzymes, due to which the drugs are metabolized very fast, and it leads to suboptimal concentration of antiretroviral drugs. So the rifampicin is so feared about rifampicin drug interactions, and this is a slide to show how it reduces the levels of ART. It least affects efavirenz, as you can see in the slide. And when given at a standard dose, rifampicin and efavirenz, when given at a standard dose of 600 milligram daily, the trough concentration of efavirenz, which is the best predictor of its virological activity, remains well above the concentration to suppress HIV in vitro among the vast majority of patients concomitant rifampicin. Because of its potency, simplicity, and proven clinical efficacy, that's why we have the standard use of efavirenz 600 mg with 2 NITI along with rifampicin-based tuberculosis treatment as a co-treatment of TB HIV. So this is very important. This has been seen in pharmacological studies, proven. So that's why when we are thinking of co-treatment of HIV and TB, we safely give our TLE, because at the standard dose, its virological activity is good enough. And coming to rifampicin and nevirapine, rifampicin reduces serum content by 20 to 55%, and at the same case, with subtherapeutic levels, it can lead to there are more chances of failure, there are more chances of resistance, and of course, there is overlapping toxicity of nevirapine and the first-line anti-tuberculosis drug, mostly the skin rash and hepatotoxicity. Rifampicin and protease inhibitor are the big no. When co-administered with rifampicin, concentration of many standard protease inhibitors are severely diminished, more than 90%, and this severely compromises HIV treatment efficacy. And protease inhibitor boosting strategy may result in unacceptable rate of hepatotoxicity. So it's not recommended to be tried. Higher dose should only be used with close clinical and lab monitoring for possible hepatotoxicity in case where there is pressing need to start antiretroviral therapy and no other antiretroviral drug options are available. So this is important. So now, most important take-home point is that our standard regimen TLE is safe to be given with Now coming to rifabutin, we often hear this name, we often use, I'm sure we are using it also at IRT clinics. Rifabutin is a rifamycin with an activity against the tuberculosis complex, and it is commonly used in patients with tuberculosis and HIV co-infection who are on second line ART. This is because rifabutin is a less potent inducer of cytochrome P3A than rifampicin. And although there are limited head-to-head evaluation of rifampicin versus rifabutin in the treatment of tuberculosis, these agents seem to have comparable rates of cure and relapse. It can also cause transient liver enzymes raise and brownish and other side effects, and like thrombocytopenia, leukopenia, and very uveitis. What is important to know in case of rifabutin is that see, they can CYP inducers or inhibitors can influence rifabutin concentration. So this is a complex co-treatment with antiretrovirals. What do we understand by this is that there's a different dose of rifabutin with different antiretrovirals, because even rifabutin concentration is affected by differently by all the antiretrovirals we have. For example, if we take it with efavirenz, then the rifabutin concentration dose has to be increased, and with protease inhibitors, rifabutin concentration it has to be given around 150 mg to prevent its side effects. So there's a complex co-treatment of rifabutin with antiretrovirals, and we have to remember which antiretroviral we are giving when we are giving rifabutin to adjust the dose. And it's similar to rifampicin and has significantly less, as I just said, and this may reduce the magnitude of drug-drug interaction. I just said all this that there's a complex co-treatment, so we need to know the rifabutin dose depending on which ARV we are giving. So if your patient whose rifabutin dose was decreased, this is an important point to avoid drug interaction related to co-treatment with antiretroviral therapy, subsequently stops taking the antiretroviral drug. For example, he was taking ritonavir and he stopped taking ritonavir drug. Then there's no drug to decrease there's no drug interacting with rifabutin, and the resulting rifabutin concentration can become subtherapeutic, putting the patient at risk of tuberculosis treatment failure or emergence of rifabutin resistance. So this is very important that if the patient is taking rifabutin dose adjusted with some ARV and that antiretroviral we have stopped, then we have to watch for rifabutin dose also. Rifampicin, this is on some special scenarios. As I said, that rifampicin suppresses, we have already discussed this, the bioavailability of boosted protease inhibitors. Rifabutin is more effective in this case, and it does not inhibit effectiveness of these boosted protease inhibitors. So whenever boosted protease inhibitors are used, we substitute rifampicin with rifabutin for the entire duration of anti-TB treatment, and dose is 150 mg/kg. Rifabutin is available as a used drug and not in FDC, and it should be treatment should be initiated as soon as the TB diagnosis is made. The patient has to be initiated with second line ART, and if rifabutin is not available, which may be in some of the cases, still the patient can be started with rifampicin-based anti-TB treatment. However, efforts should be made to, if they are protease inhibitors, all efforts should be made to replace rifampicin with rifabutin. And as I just said, the rifampicin-based anti-TB is co-administered with boosted PI-based ART. HIV will develop drug-resistant mutant because, as I just said, rifampicin reduces the levels of the CRT. So the key points is that the newly evolved daily anti-TB treatment with 3 drugs in the continuation phase is aimed to reduce relapse rate and drug-resistant TB. The standard first-line anti-TB treatment will be provided at ART centers for all HIV patients, whether they are new or previously treated, and drug-resistant TB treated in the designated drug-resistant TB centers. And last but not the least, all the PL-HIV with TB have to be initiated on ART as per NACO guidelines to reduce the mortality and to prevent other life-threatening opportunistic infections. Thank you.
Thank you, Dr. Nandya. I think in a very nutshell, you have very clearly explained the variation or the new additions to the national guidelines. So we have seen previously in previous sessions, we had questions related to, because in ART operational guidelines, which were issued last October 2018, it were there that for the patients who are new TB patients or who are previously TB patients, the treatment regimens were different. That means the new patients, it is written that we will give 6 months of regimen, and for the previously treated, we will be giving 8 months. But after the ART guidelines were released in October, in December, we received the revision of the guidelines by RNDCP. So the same revised guidelines will be in effect at the ART centers also. So now it is very clear that whether the patient is a new patient, TB patient, or the patient is previously treated patients, the regimen, the first line regimen, the patient will be having the first line regimen. Yes. That is the 6 months. But here also important thing is the naming convention is same. Yes. As you said, yes. The patient will not be said as new, but patient will be named as previously treated. In the HIV TB records, we will name that patient under previously treated patient, but will give the treatment, TB treatment for 6 months. That is the 2 months of HRZE and 4 months of HRE, which is there. And the second thing, which is a major change, has happened in the weight band. So previously, the weight band, we had difference of 15 kgs, if you see. So that is from 25 kgs to 39 kgs. So now that has been reduced to only 9 kgs. That is 25 kgs to 34 kgs. So again, the 5 categories, 5 bands are there, but the difference is reduced. So these were the major things, apart from all these. So I think now it's time to take those 2 questions again, which we have seen in the pre-test. So now that would be very interesting to see now how would you rate and react to these questions. So I request all that on your screen you will be having the post poll. So let us see how audience take these questions. Because when we had this pre-test, so people, of course, this is an anonymous poll. We won't be able to get or know which ART center is giving which answer, but there was a variation. We can see in the chat, people are saying thank you. So thanks for the appreciation, but we are not ending here the session. We still have 5 minutes left. We will discuss the answers of these polls. So be here, be patient, give us your 10 minutes more. We will be discussing these questions and answers once you will finish this. Thank you all. Thank you for attempting the poll. So now let us discuss what were the questions. So now these questions again you can see on your screen. Okay, so first question was that at the ART center, you need to start the drug-sensitive TB treatment to the PLHIV. And he is having history of TB that he has taken TB treatment for only for past 2 months. That means it is clearly a LFU patient, which has now come. You need to start treatment again. So which regimen would you recommend? So of course, it will be CAT1 because the answer is CAT1. That is the first option because as we discussed in this session, as per the new guidelines, there is no term as CAT2. There is no term as CAT2, although the patient will be categorized, and when we write in the HIV TB register and notes, the patient will be written as categorized as previously treated, but the regimen will be given for 6 months under CAT1. Right. So even Dr. Nanya, can we say CAT1 or are we using some other terminology?
No, we still, because the drug charts and the treatment charts, we still say CAT1 only for drug sensitive treatment. Basically, it's drug sensitive TB treatment.
Okay, so basically it's drug sensitive TB treatment. Yeah. In a long sentence,
you can say. Yeah, but lots of treatment cards are still having the old records. They still have CAT1, CAT2 courses. So it's, we still take on CAT1. They do that, but it's called drug sensitive TB treatment. This is the present.
Okay. So the answer of the first question was option 1, that is CAT1. So now let us discuss question number 2. So question number 2 says that you needed to select the false, that is the wrong statement. First statement was that DST, drug susceptibility test for INH and rifampicin, should be conducted in all tuberculosis patients who are previously treated. So this is very, very much correct. So whosoever is coming, who was previously treated, must be checked for INH and rifampicin resistance. So this was correct. Then this is not false statement. The second statement was that all drug-sensitive pulmonary TB patients should receive standard 6-month TB regimen. So this statement is also correct. Then the third statement was that a TB patient who has received 1 month or more of anti-TB drugs in the past, that means this patient is a previously treated treatment, would receive CAT2 regimen. So now the answer of question 2 is this statement is false. As again we have discussed today, there is no CAT2 regimen, although the patient is previously treated, categorized, but we are only giving CAT1 regimen. There is no CAT2 regimen exists now. And the fourth option was that previously treated TB patients should receive standard first-line regimen but categorized as previously treated patients. This is what we have been saying again and again in the entire duration. So this statement is also correct. So that means the false statement was the third option of the second question. So now I think it's all very, very clear. Now the ART centers, because all my colleagues were we were all confused because in our operational guidelines of ART, which has recently been published in October 2018, it was written that in previously treated, you have to give 8 months. But now we know that guidelines have been changed. It's only the CAT1, that is 6 months of drugs we need to.
I think there was confusion. Like, okay, fine, we'll not give streptomycin, but we give it for 8 months. So there was this duration also. There was a lot of confusion even after these guidelines came. So 6 months for both needs to be reinforced and needs to be remembered.
Right. So here, any questions from the audience side? Anybody wants to ask anything or clarify, want to have clarification on any aspect? Please raise your hands. You can unmute yourself and you can ask. Even if you don't want to ask, you want to say something on these revised guidelines.
Yes.
Your experience or any other thing which you want to say or add something which we have just discussed. So we can have that discussion. Okay, I think not much right now. So just so that the participants would know that today we have discussed about changes in the national guidelines, national HIV/TB guidelines in the adult. Now in the coming sessions, we would be discussing the changes in the national guidelines in the pediatric group. So that would be discussing in the separate
one thing I would like
sessions.
to know how many of you are aware of this new weight band change, because this is something which is very recently that has happened. So weight band change, were you all aware of? I wanted to know that.
You can just raise your hands. We can see all the screens. We all can see each other. We can all see the screen. So thank you all for attending today's session, and thank you, Dr. Ananya. So before we go on for the feedback, I want to again tell that please subscribe the channel Initiative. If anybody of you want to watch the video of the previous recording, because whatever session we had discussed today, that would be provided to you and the recommendations. If you want to see the same recorded session in the YouTube, you can watch it on your smartphones. And if you want to receive a notification through WhatsApp, you can just send us your phone number, and on that phone number we will provide the video clips of the previously recorded sessions if you wish. Anybody, so on our email, that is initiative@gmail.com, you can provide your individual phone numbers if you wish to have the video recording, the videos of the previously initiative sessions. And I think it would be great, it would be handy, it would be on your smartphone, so you can do that. Also subscribe the channel, and I request you all that you must have received the email from our side that in the coming sessions we also would like to discuss the IPT. We have received few queries from the field on IPT, isoniazid preventive therapy. So I request you and encourage that please send us the cases on IPT. Anything, it may be the short case or the query or anything related to IPT which you feel, which we can discuss on this platform, that you can send within next week. So again, on the same email ID, that is initiative@gmail.com. And with that, so here on your screen, you will be seeing the feedback poll. I request you all to please fill in the feedback poll. With that, I thank you all the participants for all the 4 states and all other participants who are coming from different places. And thank you, Dr. Ananya,
Thank you so much.
for being with us. And again, we will be meeting you next time, next scheduled initial session. Thank you all. Have a great day.